My name is David Glaser. I am a physician licensed here in California. I'm a clinical and I'm a forensic psychiatrist with over 3 decades experience here in California. As a forensic psychiatrist, I have a deep understanding of how each system has rules and regulations. As a clinical psychiatrist, I've treated thousands of patients both in and out of the workers' comp system. My primary treatment experience is in the private sector. As a psychiatrist, I understand and I appreciate the phenomenology of serious depression and how chronic pain adversely affects depression. I'm up on the cutting edge of psychopharmacology, which has seen an explosion of treatment possibilities in the past 30 years. It is a fact that since I was a resident at LA County USC Medical Center in 1979, that in the 30 years since that time, there has been over 24 new agents added to my therapeutic quiver in treating depression. To me, it is absurd that in 2012, when we have all these possibilities in terms of treatment options, that the legislature, by virtue of the workers' comp laws, are restricting what we can do as psychiatrists. Currently, I am in the most advantageous position to comment on psychiatric care, as my current forensic practice in workers' compensation consists primarily of AMEs and some panel Q.M.Es. I have reviewed and I am familiar with the quality and quantity of the psychiatric care given to injured workers in California. I have personally reviewed over 1,000 medical records from psychiatrists who provide psychiatric care to injured workers in California. Based upon that experience, I believe I am most qualified to comment on the quality of such care. I am horrified at the quality of psychiatric care in the workers' compensation system. Were this the private sector, there would be multiple concurrent medical malpractice lawsuits revolving around treatment, which I believe is below the standard of care. Injured workers in California, they're treated like third-class citizens when it comes to psychiatric care. I can no longer muzzle my mouth and keep to myself that gnawing feeling that what is happening is both morally wrong as well as clinically not cost-effective. More than ever, treatment and intervention is about what is most cost-effective. My message is so simple. Competent psychiatric care is cost-effective. Let me use an example. In my private practice, I see a patient for 1 hour initially, and I make a diagnosis, and I come up with treatment recommendations. I define the target symptoms of depression, and I individualize treatment to the person's needs and their preferences. One size does not fit all. I generally start medication on the first visit, and I ask for a phone call on the following day. Based upon that phone call, I either have another phone call in 1 to 2 days, or I increase the dose. I'll add a medication for sleep if that is an emergent issue. I will keep a close eye on side effects. I will generally see that patient 1 week after the first office visit, and I will continue this frequency of visits until there is a substantial response to medication. But this can take weeks. I will taper my visits to every 2 weeks when there's an initial response, and will taper further to 1 month when the response becomes more robust. Between visits, I will have some telephone contact. Some patients need this more than others. Frequently, a depressed injured worker is not referred to a psychiatrist by either the primary physician or the treating psychologist. When there is a referral to a psychiatrist, he or she spends anywhere between 15 minutes and 1 hour with the injured worker. A medication is prescribed at 1 dose. The person is referred to a limited number of psychotherapy sessions and regular group therapy sessions. There is no telephone contact between visits. The next office visit is at the earliest 1 month, and sometimes as late as 3 months after the first visit. The psychiatrist then spends anywhere between 15 minutes and 45 minutes with the injured worker. There's no coordination of treatment with the psychologist. Sometimes the medication dosage is never changed. Sometimes the patient stops the medication after 1 day or 1 week due to side effects. But no one in a position of professional power knows this. What is wrong with this picture? Plenty. The psychiatric fact is that in 2012, with our many treatment options for the depressed injured worker, especially the ones with chronic pain, much can be done, but much is not done. Under proper care, there's no reason why suffering and symptoms cannot be reduced. So much money is wasted on evaluations without a proper and effective treatment intervention. So much time is lost from work. There's so much subjective suffering. Chronically depressed chronic pain patients have more pain, which means more depression. A vicious cycle is set in motion. Chronically depressed injured workers participate less in needed physical therapy, and they don't have the drive to get medically better. Without competent psychiatric care, there's a negative domino effect. People do not get better overall because they can't get better. What can we do to change this pathetic predicament? We need to make it attractive for competent psychiatrists to get involved with treating injured workers. We need to attract competent psychiatrists. We need to improve the reimbursement for psychiatric services that are currently approximately 25% what is charged by top-tier clinical psychiatrists in Los Angeles for office visits. We need to change the rules and regulations by which psychiatrists are engaged and utilized. This change will only lead to a positive cascade of more competent psychiatrists willing and able to treat injured workers. Most importantly, this will save money and improve the quality of the lives of injured workers. I believe this can be achieved, and I personally would like to be part of this process of change.